Here's a picture of the lid, the upper eyelid being flipped so that the examiner can see the surface of the inside of the lid, which is the palpebral conjunctiva lining the lid, and also if there's any foreign objects there. This slide demonstrates the proper use of the fluorescein stain strips, being really careful never to touch the cornea with the strip. You do want to moisten the strips before you touch them upon the, basically in the lower lid. You kind of pulled the lower lid down as though you were instilling an eye drop, and you touch the colored strip on the inside of the palpebral conjunctiva, or the conjunctiva lining the lid, and it will it'll kind of seep out and color the tears, and then it will wash over the sclera and the cornea, at which time you then take a special light. It has to be a black light, and you light up the area, and this is best done in a dark room, so that then you can see if the stain is picked up anywhere across the cornea, indicating an abrasion or an ulceration. In summary, we synthesize the data that has come together in this seemingly simple case, and we explore and think through. At first, when we're in novice, it's a slow process. Later, of course, it becomes automatic, but it is always there under the surface. So our working diagnosis is that it's a bacterial conjunctivitis based on the fact that it started in one eye, there is an exudate, there's crusting shut on awakening, there's generally no signs, there's no symptoms reported of an upper respiratory infection, which kind of gets us away from the viral idea. The onset was fairly sudden, so that takes us away from the idea of allergies. And in our history, we excluded a lot of the data, or diagnoses that might be eye-threatening and serious, by asking a quick series of questions in terms of what they deny. So the data that refutes serious conditions would be that they deny eye pain, they deny a loss of vision, they don't have photophobia. And when we then take a look at the physical exam findings, again, what supports our bacterial conjunctivitis diagnosis is the idea that we do see that generalized injection, we see a little bit of exudate, we don't see evidence of trauma, we don't see evidence of a foreign body, we don't see a pattern to their injection that is what they call limbic, which is circling around the iris, as we described before in some of those inflammatory conditions. And their visual acuity is intact and similar to their usual. And their pupils are equal, they're round, they react to light and accommodation, just like we would like them to be in a normal situation. In the case of the patient that we've described, who appears to have a bacterial conjunctivitis, the treatment plan is fairly simple. A broad-spectrum antibiotic is employed. In terms of basic principles of treatment, for simple, non-vision threatening infections that don't appear to have any special source, such as gonococcal, we can use a broad-spectrum, older generation medication. In some cases, we might want to go up to something like the fluoroquinolones, which are a lot bigger guns, but generally speaking, we reserve those for severe cases or cases involving corneal damage, etc. In general, something fairly simple in terms of drops. The book I know recommends using ointment at night because it kind of lasts longer. Ointment can be used during the day as well. Eye drops have to be applied fairly frequently in order to be effective. And really, within 24 hours, there should be some turnaround in terms of symptomatology. And what I always tell patients is if they're not improving in 24 hours, they're to be seen immediately by an eye doctor, ophthalmologist, or optometrist. If they haven't gotten better in 3 days, they're also to be seen. Better altogether, that is, because that's probably telling us that there really isn't a bacterial infection, that it is something else going on, such as allergic, or possibly viral that's just not responding. I usually have people treat for 3 to 5 days and stop the treatment after a full day of being symptom-free. That way, if they resolve in 24 hours, they just go another 24 and then they're fine. They can stop. Especially when you're trying to get eye drops into children, it's really difficult. Again, laying them down. Even with an adult, you can do this method, lay down and put the eye drop, even if their eye is closed, just put it near the inner canthus, and when they open their eye, the drop will go into it. Of course, you want to be sure that they clean away any of the debris from the exudate. Before applying the drops or the ointment. There are some absolute no-nos for us in primary care. You'll see in the literature that there are some recommendations for the addition of steroids in the treatment of some forms of conjunctivitis, and certainly steroids, ophthalmic steroids are used for several conditions, but that should only be under the care of a specialist. It really isn't appropriate for us to do that. We will sometimes use some anti-inflammatory medications, some mast cell stabilizers and things like that for allergic conditions. But the steroids I personally like to just reserve for the use of the specialist, and they certainly can start the patient off and we can monitor them. That's not a problem. Also, NSAIDs, non-steroidal anti-inflammatory, are to be used with great caution, and again, I would use those in consultation. And of course, topical anesthetics are something we do use, but you only use them in the office. You never send a patient home with a topical anesthetic, although they will beg you to do so because it makes their eye feel so much better if they have a corneal abrasion or other condition that irritates the cornea. Moving downstream to the nose and sinuses,